the recording in progress message. So I hope that is all right with everybody. We are recording the presentation portion of this evening, and then before the Q&A, we will stop recording. So just know that we will not be recording any of your questions this evening. So hopefully that helps you feel nice and comfy asking anything. And with that, Laura, if you want to go ahead and share your slides, I will start kicking us off while you are sharing your desktop. So my name is Christy Cooper. I am the Family Support Director here at Down Syndrome Diagnosis Network, or DSDN, because our full name is a bit of a mouthful. And I'm so happy that you're joining us this evening. And I'm so grateful to Dr. Cifra-Bean for being here. She is a friend of the organization. And I will read her bio in just a minute, which makes her very special. And I'm sure you all will agree. But she is going to be walking us through the AAP, or American Academy of Pediatrics, health supervision guidelines when they come to kiddos with Down syndrome. So we're going to be talking through what they say and a little bit of background about why. So this is mostly geared towards the parents of children who are in their early stages, so about 0 to 3, with a special focus on 0 to 1, just because there are so many questions for that age range. But we hope that you will join us and learn a little bit, no matter how old your rocking kiddo is. So let me introduce Laura here, and then I will turn it over to her. So Laura Cifra-Bean, MD, is a general pediatrician with over 25 years of experience in helping families. She has a special interest in people with developmental disabilities, especially Down syndrome. She earned her undergraduate and medical degrees from Case Western Reserve University and did her pediatric training at Rainbow Babies and Children's Hospital. In 2022, she joined the Down Syndrome Association of Northeast Ohio, or I think of it as DSDN, because again, less of a mouthful, formerly known as the Upside of Downs, as their medical outreach director. She has presented workshops on Down syndrome at national and regional conferences. She is a past board member of the National Down Syndrome Congress, or NDSC, and current member of the Down Syndrome Medical Interest Group USA. She has 3 children, including a 31-year-old son, Chris, who rocks an extra chromosome. So she is also a rockin' mom, like a lot of us on this call. So I will turn it over to you now, Laura. Thanks for being here.
Hi, thank you so much for having me. So we're going to go through the American Academy of Pediatrics Health Supervision Guidelines. I'm not going to go through them word for word, but hit the highlights and give you some resources that you can use. So first, just a little disclaimer that by viewing or participating in this webinar or accessing it or viewing any information on the DSDN website, that this does not constitute a doctor-patient relationship, and that any questions that you have specifically about your child would need to be referred back to your own doctor, because we can't provide any medical advice specifically. And the information in the webinar is just for general information purposes and is not medical or legal advice. And Christy and I discussed this, and the DSDN agrees with the disclaimer also. Okay, so the American Academy of Pediatrics, that's the big professional organization for pediatricians, has had the health supervision for children and adolescents with Down syndrome since 1994. And the most recent version came out in the spring of 2022. The full guidelines can be accessed at this link or at this QR code. And I highly recommend downloading the whole guidelines and looking through them and taking a copy to your child's provider so you make sure that they have them. You know, one of our jobs is being advocates, as we are also parents. There are Down syndrome clinics across the country that run in various ways, where it could be a doctor, a family practice doctor, a pediatrician. Sometimes there are therapists, social workers, and a multidisciplinary team in like the big clinics like Denver and Boston and Pittsburgh and Cincinnati. But a lot of places don't have access to a Down syndrome clinic. And usually the Down syndrome clinics don't take care of all the primary care. So this is definitely a good resource to share with your child's primary care provider. There are a couple other ways the information is presented. There is this one-page chart that you can see exactly what should be done at every visit. So this also is a good thing to have and share with you. The provider can be accessed at this link or this QR code. So I'm pretty sure everybody knows a QR code, but just shine your camera at that and it will take you right to the link. And then one more version, there's a family-friendly version on healthychildren.org, which is a website associated with the American Academy of Pediatrics. It is in English and Spanish, and it's by age. So it's broken up from birth to 1 month, 1 month to 1 year, 1 year to 5 years, 5 to 12, and 12 to 21. And they have a handout for each age. So this is a very convenient way to look at this at your child's age and see exactly what should be done at the checkup in terms of what should be discussed, what lab work should be done, what testing should be done, and what diagnoses to keep in mind. So these, another good thing to download and share with your child's doctor. So starting at birth, at birth, if the baby is known to have Down syndrome or is thought that they may have Down syndrome, we'll get a very thorough evaluation, and some special things we look at are to see if there's any heart problems, GI problems, feeding issues can be very common, or eye problems such as cataracts, as well as just a whole general physical exam. And I'm just going to go briefly through some of the heart problems. And if you want these pictures, again, they can be found at this link or this QR code. So the typical heart is figure A, where there's nice dividers between the chambers on the top, the atria, and the chambers on the bottom of the ventricles. And then they have nice valves in all the right place that go between the blood vessels and the big parts of the heart. In an AV canal, which a lot of babies with Down syndrome are born with, there's holes between the bottom chambers, the ventricles, and the top chambers, the atria. And that leads to mixing of the blood that has oxygen in it and doesn't have oxygen in it. And that can lead to the baby's oxygen level being low. In an atrial septal defect, there's just an opening between the top chambers. And in a ventricular septal defect, there's just an opening between the lower chambers. Tetralogy of Fallot is not all that common in babies with Down syndrome, but it can occur. And that's when there's some abnormalities in the valves, in a thickened heart muscle, and again, the hole in the heart, and then the aorta is kind of in a different place, which makes up the 4 things of tetralogy of Fallot. In a patent ductus arteriosus, also known as a PDA, the blood vessel that when the baby's inside the mom's body, the blood does not go to the baby's lungs, it goes instead to the placenta. And that's that ductus arteriosus is supposed to close in the first couple days when the baby takes a breath, so that the blood now goes to the lungs and gets the oxygen. Sometimes that doesn't close, and that can be an issue. The gastrointestinal problems we look for at birth usually present with vomiting or feeding issues or not pooping, duodenal atresia or duodenal web, where the first part of the intestines is not connected correctly to the stomach. And obviously the food cannot pass from the stomach into the intestines then. Or Hirschsprung's disease, where there's some abnormal nerve cells in the large intestine, so it's very narrow and the stool cannot move through, and it would end up obstructing, also producing vomiting. So testing at birth would include blood work, karyotype to show the chromosomes if that's not already done, or just to confirm. A complete blood count with differential, that's like the CBC, to check for blood abnormalities. Thyroid function tests. I'm from Ohio. In Ohio, that's included in the newborn screening, but it isn't included in all states. So sometimes the pediatricians or providers need to check that. And then other tests, all babies should get an echocardiogram. All babies with Down syndrome or suspected to have Down syndrome should get an echocardiogram, because sometimes there is not a murmur or other sign of difficulty in the first day of life, but you don't want to send a baby home and then have them have trouble breathing or have their oxygen level drop. Hearing screen, all babies get a hearing screen now, but especially babies with Down syndrome. And then babies with Down syndrome would qualify for a car seat challenge to make sure that the baby's oxygen level stays normal while it's in the car seat. Just a word about one thing that's sometimes found on the blood count. There's a disorder called transient abnormal myelopoiesis, and that's when there's an increased number of immature white blood cells. And that most of the time this goes away by itself, but it can cause some issues. And it does put the baby at risk for leukemia in the first 4 years of life. So it needs evaluation by a hematologist and to be followed by a hematologist, a blood specialist. And then from birth to 1 month, a lot of what we do is monitoring feeding and weight gain. Babies with heart defects can have a lot of trouble with feeding and weight gain, but even babies with Down syndrome who don't have a heart issue, also just the low tone can have some issues with feeding and weight gain. A lactation consultation can be very helpful. And the Massachusetts Down Syndrome Congress has Julia's Way, which is an online virtual lactation support that can be very helpful. The doctor would be making sure that the baby is referred to early intervention, discussing increased susceptibility to respiratory infection. So babies with Down syndrome can get much sicker from colds or viruses than typical babies. So you really want to be preventive. It's hard when there's older siblings, but especially that first year of life, trying to keep the baby from getting sick is very important. And then the doctor should also discuss cervical spine safety. I want to just make sure you guys understand what atlantoaxial instability is. It's a big word, but the atlas is the first cervical vertebrae in your neck, and the axis is the second. And in a spine that doesn't have atlantoaxial instability, when you move your head or neck, everything moves together and the spinal cord is fine. In atlantoaxial instability, the first vertebrae, the atlas, can move on the axis and then end up pinching the spinal cord. And because of the ligamentous laxity, this is thought to be more common in people with Down syndrome. Most of the time it's asymptomatic, but it is a concern we always keep in the back of our minds. And this is from the American Academy of Pediatrics. So signs of atlantoaxial instability would include changing how a person walks, uses their arms or hands, a change in bowel or bladder control. If they present like with a stiff neck or a tilted neck, that's very serious in a person with Down syndrome. That shouldn't just be like, oh, they slept funny. That definitely needs a call to the doctor. New onset of weakness or a decreased activity level. Usually the doctor would start with an x-ray of the neck in a neutral position and go from there. But if any concern remains, then seeing a pediatric neurosurgeon or a pediatric orthopedic surgeon, depending on your area, who's the specialty, is what should be done. And again, this QR code can take you to this page. And then there's precautions that are recommended for all children with Down syndrome because of the risk of atlantoaxial instability. And again, this is from the AAP. So avoid excessive flexion or extension of the neck during any anesthesia, surgical, or radiology procedure, so the spinal cord is protected. Avoid the trampoline unless it's part of a supervised training program with professionals. And just to realize that contact sports such as football and soccer or gymnastics do place the child at risk for a spinal cord injury, so extra care. So moving on, from 1 month to 1 year, again, we're still paying a lot of attention to feeding and weight gain. That's, and there are specific growth curves that can be found at the CDC so that the weight gain average is a little different for babies with Down syndrome. So these curves are more useful in infancy. Repeat the hearing test at 6 months old, even if the newborn test was normal. And then repeat the thyroid testing at 6 months and 1 year. So even if the baby had a normal test, a thyroid test at 6 months, then definitely that needs to be checked at 6 months, because sometimes that it changes between birth and 6 months. An evaluation by the eye doctor by the age of 6 months, and then a blood count and test for iron deficiency at a year. The doctor should discuss signs of sleep apnea with you, and assess for any neurologic issues such as seizures, infantile spasms, or atlantoaxial instability. Infantile spasms are a specific type of seizure that happens to babies, and it's not your typical whole body shaking, jerking. It can more like a repetitive type movement. And so if you think that your baby's doing a funny movement, which a lot of babies do funny movements, the best thing is to videotape it and show it to your doctor, because they a lot of times know what a normal movement is and what a normal movement is not. And if you have concerns about that, then always asking to see a neurologist. It should never offend a pediatrician or a doctor if you want to see a specialist just for peace of mind, because that's your right as a parent to ask to see a specialist if you're concerned. And then the vaccines are per usual schedule, and some babies might, depending on when they were born and what time of the year it is and what medical conditions they have, might qualify for RSV prevention. I just want to talk a little bit about RSV because babies with Down syndrome can get very sick with RSV. So RSV is a respiratory syncytial virus, and it's a very common childhood virus, and it's the leading cause of hospitalization in children under 5. Typically, it's a winter virus starting in October, but the last couple of years during the pandemic and everything, all the viruses have gotten all mixed up. So sometimes we're even seeing RSV in the summer now and throughout the year. So it starts as a cold with a runny nose, fever, cough, general thing. It's very contagious. So the older siblings and anybody who's sick can definitely give it to the baby. And premature birth and congenital heart disease do increase the risk of a severe infection. But babies with Down syndrome are at increased risk of infection, even if they are full term and have no heart disease. So really, this is something to be avoided. Bronchiolitis, this is when a virus, most commonly RSV, but it could be any virus, moves from like the upper airways, the nose and throat, to the lower respiratory tract, the lungs. And this is when more serious coughing would start, wheezing, the noise. Sometimes you can hear it by your ear, sometimes only with the stethoscope, breathing fast, and difficulty drinking. This is a more serious respiratory infection when we get those symptoms. Signs of difficulty breathing for a baby, regardless of the cause, would be breathing fast, usually 60 or more breaths in a minute if you count it. It's a little hard to count, but if you can count it, and that's concerning. Pulling in around the ribs or tummy or up here, like where you see the skin really sucking in, that's called retraction. That's definitely a call to the doctor. If the nose is flaring or the baby is making a grunting sound, then that's a concern. Other concerning signs would be like if the baby seems like they're pausing in their breathing or forgetting to breathe, like apnea. If there's a blue or gray color to the skin, maybe around the lips or the fingers. If the baby can't suck and breathe at the same time and isn't wetting as many diapers. So those would all be reasons to call the doctor. And, frankly, with a little baby, with a baby under 6 months old who has Down syndrome, generally the doctor would want to hear with any sign of illness just to keep an extra eye on them. There is no specific treatment for RSV. It's the kind of, when it's in the cold phase, it's just the comfort measures like usual. But in the hospital, some babies can need oxygen, IV fluids, and If it's very severe, some babies need to be put on the ventilator and intubated. So prevention is the best thing we can do by trying to keep people who are sick away from a baby, making sure everybody washes their hands. And, consider masking if you're hearing it's a bad RSV season, or if your baby's very fragile, or it's something that you or your doctor thinks, it never hurts to have people mask around a little baby and to keep the baby away from cigarette smoke. There are a couple vaccines and immunizations that can help prevent RSV now, and these are rather new, but they have been effective. And so I'm going to go over what the information was from what we call sixth season, last fall and winter, but make sure you check in with your pediatrician because recommendations sometimes change yearly on these winter viruses. So Abrysvo is an immunization that the mom gets during pregnancy at about 30 weeks of gestation if the baby's going to be born during RSV season. And then the antibodies made by the mom pass to the baby and protect the baby from RSV. It reduces the baby's risk of being hospitalized from RSV by about 57% in the first 6 months after birth. So again, here's a QR code if you want more information. Then Beyfortus is a type of immunization that's a single dose of a monoclonal antibody. It's recommended for all infants younger than 8 months during their first RSV season. And they can get the dose in the hospital or as an outpatient, hopefully within 1 week of birth if it's RSV season. And it's recommended for some infants and young children through 19 months of age in their second RSV season. And this is, again, something to talk to your provider about. And these things could change who's recommended for it during the second season. This is just some more information about Beyfortus. So definitely something to talk to your pediatrician about. And then the older type of prevention that's been around since 1998 is Synagis, which is a monthly injection that was used for premature babies or infants with congenital heart disease. So now we have all these different options, and that really would take a discussion with your OB if you're pregnant, or your pediatrician, cardiologist, neonatologist, breathing specialist if the baby's already born, to decide which one is appropriate for your child. And these are the resources that I used to compile these slides. So the QR code is for the healthychildren.org. Again, that's the American Academy of Pediatrics. So if you want to learn more about RSV, this is a very good handout, this first one, and that's what the QR code is. And these are some more resources if you want to learn more about RSV. Other respiratory infections can also make babies very sick, including influenza, COVID, and pneumonia. And there's vaccines available for all these illnesses that you can discuss with your child provider. Okay, going back to the checkups. So from 1 year to 5 years, again, we're monitoring development and screening for autism at 18 to 24 months, just as in typical kids. There is a higher rate of autism in people with Down syndrome. Sometimes it's a little harder to diagnose because there is already that language delay. But if your therapist or your doctor or you or a teacher is thinking your child is not really doing the typical development for a person with Down syndrome, that would be something to discuss with your provider, and maybe ask to see a developmental pediatrician, seek out the Down syndrome clinic where you would get a more expert evaluation. Beginning dental care, very important. People with Down syndrome, as they grow, especially through adulthood, can develop a lot of dental disease. So beginning to brush those teeth. A sleep study is recommended at age 3 to 4 years, even if there's no sign of disordered breathing during sleep. It could be signs of disordered breathing, could be snoring, waking up, making that obstructive noise, like noise, 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 and then pause, and then another noise, or sleeping in abnormal positions to kind of prop their airway up. But even if you think your child's a good sleeper, the sleep study is recommended at age 3 to 4 years. At every checkup, we continue to monitor growth and assess for feeding issues and stooling patterns, because constipation can happen, celiac disease can happen. And sometimes during these years, even in the babies who were really hard to get to gain weight as infants, sometimes people with Down syndrome start to gain weight too quickly. So that is something to keep an eye on as the person grows, because it's much easier to try to keep the weight at a healthy level than ever trying to lose weight. So, and then yearly blood work to monitor the blood count, iron deficiency, and thyroid functions again. And then regular vision and hearing screening. Your audiologist or ear, nose, and throat doctor should tell you how often to get the hearing screening. Once it's established that there is normal screening, normal hearing in both ears, usually it's every year, but usually the audiologist will tell you when to come back. And then again, vaccines per the usual schedule, and reviewing signs of atlantoaxial instability at every visit, just so you know. And then procedures can get a little more difficult at this age. So the blood draws, the sleep studies, the dentist appointment. So social stories are where, it's just a little story with pictures that kind of prepares the child for what's going to happen, so it's not so scary. And Charlie's clinic is a Down syndrome clinic in California, and they have some really good social stories. And this age is also a good time to talk to kids about body parts, appropriate touch, and privacy, because unfortunately, people with developmental disabilities are at a higher risk for abuse throughout their lifetime. So you really want to start to instill the thought that in your child that they are the boss of their body, that they don't have to be overly compliant with people. I know it is hard with hygiene issues and things like that, but still you want to start teaching them about privacy and safety from a young age. And this usually comes up as potty training begins, which is going to be different than your other kids, most likely, but it's still something that comes up at this age. And then at age 3 years, the responsibility for services and education transitions from early intervention and goes to the school district, and your child moves from an IFSP to an IEP. So that's just something to get ready for. And finding a preschool, whether you go to like the school district preschool or whether you go to a private preschool, the school district is still responsible for giving you services. Like my son's 32, but when he was young, he went to a private preschool, but we still got what they called itinerant services from the school district, but they came to him in the preschool that we picked. And then just a little bit about, keeping track of all the various medical things that might be happening with your child. My son was pretty simple as a child, but has since become much more complex medically as an adult. So it's important, if there's some medical complexity, to have a portable medical summary. They go by different names. Sometimes it's a health passport, sometimes it's other things. This was a good example I found from Children's at Dartmouth that has all the important information, name, contact, medical information, the phone numbers. And then I really like this third page, because sometimes it's hard to tell a medical provider everything. So a little bit about my child's strengths, challenges, what they do, how you can help, things to avoid, and things like that. Because sometimes in an emergent situation, you can't think straight and get all this together. So this is important if your child has any complexity to kind of summarize this. The other thing you want to do is if there are important test results or important x-rays or important imaging, if you can take a picture of some of the important things and have them on your phone. I know my son's had MRIs, and sometimes it's hard for the residents in the emergency room to go back through the medical records and find things. So if a doctor shows, hi, Chris, how are you doing?
Good, well,
I'm doing my webinar. I'll be out in a little bit, okay? Do you want to say hi? Just say hi to everybody.
hi guys.
Okay. All right, I'll see you in a little bit, okay?
Okay, we're gonna start shows, I think.
Okay. Sorry about that. So if the doctor shows me a result or an MRI or something, I just say, can I take a picture? And they're usually fine with that. And then I can show that if I need to in a different place. And so I know that was quick, but I wanted to cover all the bases and leave time for questions. So if there's any questions, I'd be happy to answer them, or if there's any part of the guidelines, I'll leave the slides up for a minute if anybody wants me to go back so they can catch a QR code or ask more questions.